Hello, everybody. Welcome again to another ASG podcast from the Technology Committee. Today, we are going to talk about tools for endoscopic management of benign luminal gastrointestinal strictures. We welcome you to this podcast. As you know, the ASG Technology Committee provides reviews of existing, new, or emerging endoscopic technologies that have an impact on the practice of GI endoscopy. The goal of our committee is to use evidence-based methods, including Medline literature search, to identify pertinent clinical studies on the given topic, as well as the MAUDE database to search and identify any reported adverse events of said technologies. Both are then supplemented by accessing related articles featured in PubMed and by scrutinizing pertinent references cited by the identified studies. We aim to use controlled clinical trials. However, in many cases, randomized controlled trials are lacking in GI endoscopy. Thus, large case series, preliminary clinical studies, and even expert opinions are used as a replacement. Technical data are then gathered from traditional and web-based publications, proprietary publications, as well as informal communications with our pertinent industry vendors. Technology status evaluation reports are then drafted by one or two members of the ASG Technology Committee, subsequently reviewed by the entire committee, and then put forth to other parts of ASG for final review. Today, I have the pleasure of inviting two committee members and friends, Venkata Akshintala from Johns Hopkins and Nikrad Shahnavaz from Emory. They were the primary authors on this manuscript for stricture dilation. So welcome. This is likely going to be a submission that gets published in the coming months. You guys did a wonderful job with this, and I truly appreciate all your efforts on the committee and on this manuscript. So thank you for joining me.
Thank you for having us, Ryan.
Thank you.
So, Nikrad, I'll start with you. Can you explain a little bit about why the committee as a whole felt like this was a pertinent topic to go through, and more importantly, why now?
Yes, thank you for having us, Ryan. I think the committee decided that this review is important because benign GI strictures, benign luminal GI strictures are common and sometimes challenging problems that we all actually encounter in our daily practice, whether as a general gastroenterologist in a community hospital or as an advanced endoscopist in a referral center. And there have been some evolutions in basically the tools and techniques that we use to manage them. The last report from the same committee actually was from 2013. And so there have been some evolution, some emerging technologies, and also further studies about the traditional tools that we felt that it's necessary to write this review again.
Yeah, I agree. I think there's been a lot of change in technology, some updates of older technologies, but also I think there's been some changes in technique as well. So I agree. It was an optimal time. It was about that 10-year mark from the last one. So I agree, and I was very supportive of this document. Venkata, why do you think this is something that all of our members should read, and perhaps some of our patients should read? What are the aspects of the manuscript that will really kind of hit home with them?
Sure, Ryan. I think this is a very comprehensive review of everything that is available and the do's and don'ts. We have highlighted that in the document as well, of how to approach from a technique aspect. I think this would be very good review of the available technologies and the techniques for the practitioners, and something that the patients also can also look up and ask about things that are evolving. For example, the drugs, the injectable antifibrotics that are evolving and coming up, and the boogie cap, some new devices that are becoming available too. So this will be good for the providers and for the patients too, for a comprehensive review.
Do you guys both believe that there's still room to grow in this space, or do you think we're starting to get to the point where things are kind of maximized?
Yeah, I think there is room to grow basically in different, well, obviously our traditional tools like bougie dilator or balloon dilators, they have been proven safe and effective. But when we deal with basically refractory or recurrent strictures, especially in some difficult anatomical positions, then that's when we need more precision therapy, and also we need to deal with these recurrent or refractory strictures. Emerging technology is very promising, but when we were reviewing with Venkata, we noted that, I mean, I noted that most of the data behind the emerging technology are kind of either small clinical trials or basically short-term outcome evaluations. So I think there is still a long way to go for prove the basically promise and effectiveness of the new technologies, and I think still we need new technology for the management of especially refractory GI strictures.
I agree with Nikrad, especially about the unmet need that he highlighted about the refractory and relapsing strictures. So yes, we have current dilators that do a pretty good job of opening up the stricture. But we know that once you open up the stricture, there is local inflammation, myofibroblasts get activated and attracted, there is more scar tissue forming. So we go into the cycle of again and again having to dilate too many times. And so this is something we want to break. And that is where anti-fibrotic drugs look very promising. So historically, again, we have highlighted this in this review of mitomycin C that is available. But the more evolving and interesting things are, for example, the paclitaxel coated balloons. So that has been used in some vascular application and urethral applications. So these drugs, when we inject, for example, steroids, they diffuse out. So they won't stay there for much longer. So they won't be much long lasting. But the newer formulations have ability to stay there and inhibit the myofibroblasts for much longer. So again, there is still a good unmet need on the refractory and relapsing strictures. So we do think that we need such, we should be encouraging such technologies that are evolving.
Yeah, I think that, we do a really good job and have the right tools for relatively straightforward strictures. But you guys mentioned relapsing and refractory strictures. The other groups that I think we struggle with are strictures that are initially very tight or strictures that are very long. So I think I agree with you completely that we're not quite there. We certainly have adequate tools to kind of make some progress, but there are still pockets or groups of people who aren't really benefiting, or at least we could still help. I totally agree. Venkata, when you look at this paper as a whole, what are your kind of favorite parts, and what do you think is the kind of the coolest part of the manuscript?
The coolest part is the new things that we have shown. The boogie cap, I think, is very interesting. The isoflip is also a new part that was not there previously. And as Nikrad mentioned, there has been a good evolution of these devices. So it was prime time for us to update. So for me, highlighting the new things and things that are in development is the coolest part.
Nikrad, what do you think? What did you enjoy the most about writing and subsequently reading through this?
Yeah, I agree with Venkata. Number one, I really enjoyed learning about new technology and basically things that was completely new compared to the previous report. But also, I enjoyed, and I think that's a cool part of this manuscript, that we also touched on patient selection, technical consideration, do's and don'ts of the doing procedures, even some new studies showing that some of the techniques that we were using before is not needed, like rule of three is not something that need to be definitely followed. And you can basically new studies has clinical trials has shown that it's safe still to go above the rule of three. But also we touch actually on future directions, and also we touch on the cost and environmental impact of the basically green endoscopy, and also sustainability of these devices.
Yeah, and that's what I think adds a new flavor to the updated document compared to previously, because I can tell you in 2013, I'm not sure there was a much of an interest in green endoscopy or some of these other things. Um, what do you, Venkata, do you think the future of this is in some sort of pharmaceutical, or do you think it's a pharmaceutical combined with something mechanical, or do you
I
think
think
it's
you're spot
overall
on,
hard to
Ryan.
predict?
Yeah, I think again, it's hard to predict the future, but if I have to make a prediction, I think it would be a combination of drug device, because we are so well suited in the endoscopy world to be able to access the site with our endoscope and deliver the drug at the site of interest without having systemic complication. So that's the reason that balloon with the drug-coated balloon, very similar to the ones used in cardiology world, drug-coated stents. Our drug-coated balloons now are more promising.
Yeah, I think you're 100% right, and probably something that we haven't leveraged enough in GI overall is just what you said, that we can access so many structures, whether it's a long esophageal stricture or a Crohn's stricture of the colon or a pancreas cyst or whatever it may be. There's so many things that we have direct access to, that we're probably under studying and under evaluating, how to make it go forward. And some of these things that I just mentioned, people have tried things. People have tried to create programs, for management of, pancreas cysts and injections in pancreas cysts. But very few places have really created programs, and have good data to show, high quality outcomes. So I agree. I think, this is obviously a bit of a digression from this topic, but certainly related, that we have access to all these things, direct access. We can stare at it, we can touch it, we can, do a lot of things to it, and we're probably undervaluing that aspect. So I would like to see that aspect grow in the future. I kind of suspect the same as you do, that it's probably going to be something that's a little disruptive. Um, a combination of pharmaceuticals and devices or accessories. The hard part is oftentimes finding a company where you can marry those two things, because device companies don't necessarily want to go down the rabbit hole of pharmaceuticals and vice versa. So you really have to find two willing partners, or, a really novel type company, um, to go forward with this. Um, Nikrad, one last thing before we wrap up. What would you say are the kind of two tips you would give people about managing, let's say, esophageal strictures, and then I'll have Venkata do colon strictures.
Yeah, well, I would say, based on this review, I would say that number one tip is that the traditional tools, basically balloon and fixed or diameter dilators, are still safe, they are still cost effective, and they are still basically efficient in the hands of the experienced operator. So we need to kind of be comfortable and become basically mastering their use based on the location and the type of the stricture. Number two is that patient selection and also selection of your tools based on the location and the type of the stricture. Are we talking about esophageal stricture? Basically, is it short? Is it long? Is it simple or basically complex? So we need to do a good patient selection and tailored our treatment based on that. So that's number one. And number two, I would just say that I mean, I would look always for new emerging methodology, technology and tools, because there are cases that we can use them, as I said, as we talk, like Fujicap or Isoflip, or even I don't know if we touch about it, but like a self-expanding metal stents. Basically, these are the new tools that in certain cases, even lumen opposing metal stents have basically used in certain cases. So patient selection and is the, I think, the key for success.
Yeah, the other thing particular, to esophageal, but really any stricture, is just persistence. Persistence and kind of a plan. If you
Hmm.
think that a patient with a stricture that's only open to 6 millimeters is going to get one dilation and be miraculously better, they're not. They're going to need several
Hmm.
dilations over a short period of time,
Hmm.
and that requires a lot of effort on a lot of people's part. So I think being persistent is huge. A little bit of a trickier question. Any additional insights when it comes to, small bowel or colon strictures, Venkata?
That's a little tricky and not the most conventional and common. But in the setting of inflammatory bowel disease, anastomotic strictures, inflammatory radiation, all of these things, we can access it. The tools are very similar. And so principles are also very similar. Some smaller size randomized control trials also have shown to be efficacious, like this approach to be effective in the long-term follow-up as well. So things are looking promising, as Nikrad mentioned. The self-expandable metal stents, lumen-opposing metal stents have also been used in this context, but that has been discussed in a separate document.
Well, look, I really appreciate you guys doing this manuscript. Again, I'm happy with how it came out, and I think it will be a useful document to the readership and also to the society. So thank you for your hard work. Thank you again for taking time out of your day today to join me for this podcast. And we appreciate your hard work and insight. Thanks again, guys.
Thank you, Ryan.
Thanks, Ryan, and to the committee as well.